Surgical Procedure Series. Atraumatic tooth extraction and ridge preservation. This surgical procedure is going to be demonstrated on a patient undergoing a full mouth reconstruction. Teeth number 10 and 11 are to be extracted as a step in reconstructing the patient's maxilla with an implant-supported, fixed, complete denture. Teeth number 12 and 14 are implants that were placed several years ago. The initial clinical status of this patient demonstrates a partially edentulous maxilla with teeth number 10 and 11 remaining. Topical anesthetic is applied to the buccal and palatal of the extraction site. Buccal and palatal infiltration of local anesthetic is achieved using lidocaine 2% with 1 to 100,000 epinephrine with a 30-gauge needle. A periodontal probe is used for crustal bone sounding. Using a 12-blade, circular incisions around teeth to be extracted are made. A 15C blade can also be used. A peritome is used initially to sever the PDL around the tooth. After severing the PDL, a mallet is used along with the peritome, mesially and distally, compacting bone and luxating the tooth. If facing excessive resistance, the surgeon can switch to a smaller P2 peritome to create space. Compact the bone using the peritome mesially and distally. If needed, palatally. Take care not to use it buccally, as this could fracture the plate. Minimize buccal lingual movement to prevent plate fracture. For this part of the procedure, the surgeon is switching back to the P1 peritome. The goal is to sever the PDL and compact the bone. This creates a larger socket around the tooth. The mobility of the tooth is determined by using the ends of two metal dental instruments. This creates a larger socket around the tooth. Extractions are performed with a number 150 forceps using a slight rotating and pulling movement. Be careful to limit buccal and lingual movements. Extract the tooth as atraumatically as possible, using a slight rotating and pulling movement. Degranulate the sockets and irrigate with saline. Eliminate all granulation tissue and ensure the socket is bleeding. Use any curette you are comfortable with. Inspect the inside of the socket with a periodontal probe or any blunt instrument to see if there are any perforations, dehiscence, or fenestration. Tooth number 10 has walls intact to the apex with no perforations, and tooth number 11 also has all walls intact. The sockets will be grafted with new os. In this case, the cancellous, small particle size of 0.25 to 1 millimeter is used. New os is distributed by the ACE Surgical Supply Company. It is packaged in a convenient Dappen dish which comes in a sterile package. This is the 0.5 gram Dappen dish. New os is a bone graft material used to regenerate osseous defects. It is mineralized bone that has been sterilized and specially processed from a bovine source and devoid of all organic material. This grafting material has been used on hundreds of thousands of patients and has proven to be safe and effective. This bone graft has the same morphology, chemical composition, and physical properties as human cancellous bone. This is evident when materials are viewed with an electron microscope. The large and small pores and the large surface area act as an excellent scaffold for osteoconduction. The graft is completely hydrated with saline until it achieves a workable consistency. Sterile gauze can be used to soak up any excess saline. Either sterile saline or the patient's blood can be used to hydrate the material. After evaluation of the sockets, it is determined an additional 0.5 grams of grafting material will be added to the Dappen dish and hydrated to a workable consistency. The new os can also be mixed with autogenous bone if desired, when grafting larger osseous defects. The grafting material can be delivered to the defect with either an instrument like a periosteal elevator or a syringe. Here, the graft is being loaded into a syringe. A periosteal elevator is being used to load it into the syringe. The material is placed into socket number 11 with a syringe, up to the crest of the ridge. Care should be taken not to pack too firmly and not to traumatize the buccal tissue. And sterile gauze is used to gently condense the particles. Here, the graft is placed in socket number 10. It is delivered to the coronal aspect of the socket with a curette and then transferred to the socket with a number 7 periosteal elevator. The material is then condensed with sterile gauze. It is extremely important that after degranulation, there is adequate bleeding into the socket. It is necessary for blood vessels and osteoprogenitor cells to invade the scaffold, which results in bone regeneration. The new os is gently packed to the crest of the ridge, and excess or loose particles are removed. Also, any loose soft tissue is cut away. The resorbable collagen plug, or RCP, is distributed by the ACE Surgical Supply Company, and each RCP comes in a protective plastic capsule that comes in a sterile package. The resorbable collagen plug is collagen that has been sterilized and specially processed from a bovine source. It is excellent for containing graft material in an extraction socket. It acts as a soft tissue compatible scaffold that allows epithelium to migrate over it. In addition, it prevents debris from the oral cavity from entering the graft. Since it is resorbable, there is no need for it to be removed with a second surgery. The RCP can be molded to fit the coronal aspect of the socket in several ways. First, a couple of sections of the collagen plug are cut. A section of the plug can be compressed using any flat instrument, or the surgeon's fingers can be used to mold the sections. Some clinicians will cut a section and take it to the grafted socket and then will gently compress the section of plug over the graft. The compressed RCP sections are held over the site and cut to the appropriate size. They are then placed over the graft and the edges of the RCP are tucked under the gingiva. The suture material used is 5-0 PGA, which is equivalent to Vicryl. Chromic gut suture material could also be used. Curved Castroviejo needle holders are used in this procedure. Cross mattress sutures are placed over the RCP and not through it. The goal is not to close the socket, but to keep the plug in place. There is minimal tension, primary closure is not attempted. At post-op, it is normal to see epithelium closed over the socket and particles of the bone graft material piercing through the tissue. The patient will rinse with chlorhexidine for 7 to 10 days following surgery. There should be no rigorous rinsing, just hold and spit. Rinsing should be done 2 to 3 times daily. Some practitioners may ask their patients to rinse with warm, salty water instead. Soft tissue healing takes 4 to 6 weeks, but signs of tissue granulating over the RCP is seen much sooner. The following are some of the postoperative instructions that should be given to the patient after surgery. For the first 24 hours, place ice packs on the outside of your face over the surgical site. 20 minutes on, 20 minutes off. If bleeding occurs, apply pressure by biting on several folded gauze pads for 30 to 45 minutes. If bleeding continues, call the doctor. Beginning the second day after surgery, rinse with chlorhexidine if prescribed by your doctor, or rinse with 1/4 teaspoon of salt placed into an 8-ounce glass of lukewarm water. Rinse 3 times daily. Soft foods for the first 48 hours. Avoid chewing directly over the area of surgery. Use prescribed medications as directed by your doctor. Call if you experience any of the following problems: fever of 101 degrees Fahrenheit or greater, excessive bleeding, pain beyond 72 hours, and any unusual symptoms. Return as scheduled for your follow-up appointment.